Olivia. Welcome back to your endocrinology chapter. In this section, we'll be going over the synthesis of our thyroid hormones, so T3 and T4. We'll also be talking about some of the pharmacology. I know biochemistry can be kind of a challenging topic, but I think if you get this down, this will really help you understand some of the pathologies that we'll talk about with your thyroid in later videos. So I'd highly encourage you to take the time to really dig into this video. First, I want to orient you to this image over here. This image will help us understand the production of our thyroid hormones. So first we have iodine. Iodine is going to be taken up and entering into our thyroid cells. Once inside our thyroid cells, thyroid peroxidase enzyme is going to be a really key player here that is going to be oxidizing and organifying our iodine. And what that means is we are basically going to be converting our iodine to a form that's going to be attached to this very important protein, thyroglobulin. And as we attach the iodines to the tyrosine molecules that are attached to our thyroglobulin, that is either going to make our diiodotyrosine or our monoiodotyrosines. Those are going to be our building blocks that will later turn into our thyroid hormones. Thyroid peroxidase enzyme is going to come back, it's going to couple these, and then finally we are going to end up with our thyroglobulin. Our thyroglobulin is that important building block that has all of our thyroid hormones attached to it, and this can hang around for a little while depending on how much thyroid hormone we need to release, and then it can be cleaved once more to release our thyroid hormones into our serum. And once we enter our serum, that is when thyroid binding globulin, this is going to be a different molecule than thyroglobulin. Thyroglobulin and thyroid binding globulin sound very similar, but they have very different jobs. Thyroid binding globulin is going to bind T3 and T4 in the serum and make sure that they don't get marked for destruction or just gobbled up. It's going to make sure that they actually reach the tissues that they are supposed to reach. And then once they do reach the peripheral tissues, 5' deiodinase is going to be the enzyme that is going to convert a lot of our T4 into our T3, and T3 is going to be a little bit more potent and a little bit more active. So once our T4 has been converted into our T3, then this T3 will exert most of the effects of thyroid hormone in the rest of the body. So that was an overview of this pathway. Diving into a little bit more of the specifics here, all of this is going on in the follicles of the thyroid. Very generally, we're going from iodine and combining that with tyrosine to make T3 and T4, and then T4 is of course converted to T3, the more potent form peripherally. Thyroid peroxidase is going to be that enzyme that we saw over here that is responsible for the oxidation, organification of iodide, as well as coupling our monoiodotyrosine and diiodotyrosine. So let's quickly talk about the coupling of our monoiodotyrosine and our diiodotyrosine. So our diiodotyrosine, just like it sounds, is going to have two parts, and so when we multiply that by 2 and combine 2 of them, it's going to make sense that we get our T4. Conversely, when we have one diiodotyrosine and we add it to one monoiodotyrosine, mono the prefix meaning one, so we have 2 plus 1, then we get T3. So if our thyroid peroxidase coupled 2 diiodotyrosines, we'll get T4. And if our thyroid peroxidase coupled one monoiodotyrosine and one diiodotyrosine, then we'll get T3. The coupling of the monoiodotyrosine and diiodotyrosines usually occurs while these are attached to thyroglobulin. Remember, thyroglobulin was right over here. It's that very important thyroid hormone substrate, and it's going to be very important because it contains all of these tyrosines, and these tyrosines are what is going to get iodinated by thyroid peroxidase. Remember, thyroid peroxidase is adding our iodine to the tyrosines on our thyroglobulin, and then once those tyrosines have been added to our thyroglobulin and we get our diiodotyrosine or our monoiodotyrosine, then we can finally couple these. Depending on how we couple them, we'll get either the T4 or T3, and then we're at this step over here where we have our T3 and our T4 still attached to thyroglobulin, most likely within our follicular cells. And our thyroglobulin can remain in this state with our T4 and T3 stored inside our thyroid cells for quite a while. But when we're ready to release our T3 and T4, then we are going to do cleavage of our thyroglobulin. We are going to have the T4 and the T3 released into circulation. A quick note here, because thyroglobulin is usually released along with the release of T3 and T4 from our cells, it can be a great differentiating factor for you in a board style question to tell if someone has been taking exogenous thyroid hormone or if that thyroid hormone has been produced endogenously. Very similar to how C-peptide levels will only be elevated if insulin was produced inside the body, but when you give exogenous insulin, you won't see that elevation in C-peptide. The same thing goes for here. If you see elevation in thyroglobulin, it's most likely that the thyroid hormone was produced endogenously. But if you don't have this elevation in thyroglobulin, it's quite possible your patient has been ingesting exogenous thyroid hormones. So a key point to be aware of there. And then once your thyroid hormones are released into the serum, they're all alone in the world, they will need to find a thyroid binding globulin. And this thyroid binding globulin is made by the liver, and it's going to be the protector of our T3 and our T4. It binds T3 and T4 in the serum, and it's going to prevent the destruction of these hormones. Finally, when these hormones do reach their peripheral tissues, then we have 5' deiodinase. This is going to be the enzyme that's converting our T4 to T3, which is the more active form in our peripheral tissues. And now finally, our thyroid hormones are ready to do their job. But why is this clinically relevant for you? Well, it's important to be aware of how this process works because there are several key drugs that can inhibit different steps in this process. First are thyroid peroxidase inhibitors. These are also called our thionamides, and these are going to be propylthiouracil, or PTU, and methimazole. And both of these do exactly what the name says that they do. They inhibit thyroid peroxidase. So you can see our thionamides labeled over here as inhibiting our thyroid peroxidase, and they're going to be incredibly useful for treating different types of hyperthyroidism or thyrotoxicosis, because when we have too many thyroid hormones, they're going to be great at slowing down this pathway because they're inhibiting the main enzyme in this pathway, right? They do each come with separate side effects, however, and these are also going to be high yield to be aware of. So propylthiouracil is notorious for attacking cell production. It can cause agranulocytosis, aplastic anemia, all of these different disorders of cell production. And then additionally, it's also hepatotoxic. Both of these can be hepatotoxic, but propylthiouracil is known more for its hepatotoxicity, so something to be aware of and monitoring there. Additionally, methimazole has its own set of side effects, so it's kind of pick your poison here. I think the most important side effect to be aware of with methimazole is aplasia cutis if it's administered in the first trimester. So a lot of times if you have a pregnant woman who is hyperthyroid, they will recommend that you give propylthiouracil at least during the first trimester, and then maybe transition to methimazole after the first trimester just to avoid this risk of aplasia cutis. It also can be present in breast milk, so it's incredibly important to make sure that we are titrating these levels appropriately and choosing the right drug for our breastfeeding moms. Our second class of drugs here are going to be 5' deiodinase inhibitors. Remember, 5' deiodinase acts peripherally to convert T4 to T3. And notably here, propylthiouracil is also active at this step. So propylthiouracil is active against two enzymes, both thyroid peroxidase and our 5' deiodinase, whereas methimazole is only going to be active against thyroid peroxidase, so a key differentiation there. And then in addition to our propylthiouracil, a lot of these 5' deiodinase inhibitors aren't actually intentional inhibitors of our thyroid synthesis. It's more of a side effect. So glucocorticoids can cause this side effect, beta blockers can cause this side effect, amiodarone can cause this side effect. Amiodarone is a drug that can actually cause hyper or hypothyroidism. We'll talk about that a little bit in a different video. But all of these drugs listed right here on your slide are definitely capable of inhibiting 5' deiodinase. Lithium is another medication that can wreak havoc throughout this entire pathway. So lithium can inhibit every step of this pathway pretty much, from iodine uptake to thyroid peroxidase and then T3 and T4 release. You can see lithium's over here messing with the iodine uptake. Lithium also shows up messing with TPO, and lithium again is messing with the release of our thyroid hormones. So it really is just wreaking mayhem and havoc throughout this entire pathway. And because of this, lithium can definitely cause hypothyroidism as a side effect. It can also cause hyperthyroidism through a couple different mechanisms. So it's important to be aware that it doesn't just have this one effect, but this is its effect in this pathway, which is important to be aware of. And then finally, perchlorate and protecanate can definitely inhibit iodine uptake. So you can see over here we have perchlorate and protecanate inhibiting our iodine uptake, and this is an important effect of these drugs to be aware of as well. So now that we've talked about a lot of the pharmacology of this pathway, I want to talk about the effect of exogenous iodine on this pathway. So there's two effects that exogenous iodine can have, and they're kind of opposite of each other. The first is known as the Wolff-Chaikoff effect. And in the Wolff-Chaikoff effect, you're going to have excess iodine administration, and that is actually going to inhibit T3 and T4 synthesis. So in the Wolff-Chaikoff effect, we have increased iodine administration leading to decreased T3 and T4 synthesis. But why does adding more reactants to this equation decrease the synthesis of T3 and T4? Well, the mechanism is thought that we form these iodo peptides, and these in turn are going to inhibit the synthesis of T TPO. So thyroid peroxidase synthesis will go down. We'll have less thyroid peroxidase available to kind of run the show and get us through this pathway, and that is the reason that we will have inhibition of T3 and T4 synthesis for several days. Now, this can be incredibly useful. The Wolff-Chaikoff effect has been historically employed to treat hyperthyroidism before we got better drugs like our thionamides. Remember, our thionamides are propylthiouracil and methimazole. So before we had these drugs around, we could sometimes capitalize on the Wolff-Chaikoff effect to decrease T3 and T4 production in acute thyrotoxicosis or things like that. And then additionally, there's a really important tie-in here that definitely comes up on STEP a lot, and that is for the treatment of acute radiation exposure. So if you're exposed to acute radiation and you have all this radioactive iodine floating around in your body, and then your thyroid takes that up, then your thyroid is going to be at increased risk for developing cancer down the line. So it's very dangerous. One way to prevent this is to convince your thyroid to stop taking up a bunch of radioactive iodine. And how we achieve that is by administering potassium iodine or Lugol's iodine. So because we've kind of overloaded the system, we've saturated it with iodine, production shuts down, and then you don't take up as much iodine in general, meaning you don't take up as much radioactive iodine, and you're spared some of the effects of this radiation. And since we're talking about the Wolff-Chaikoff effect, this brings me to the wolf on your slide, and you might be asking yourself, why is this wolf on my slide? And it's not just because wolves are sick or they're my favorite animal, but it's more because I hope this wolf helps you remember the Wolff-Chaikoff effect. And the first thing that I want you to remember about this wolf is that the wolf is in hypothermic conditions. It's really cold out here, and the wolf loves to be in the cold. And that should help you remember that the Wolff-Chaikoff effect is going to lead to decreased production of T3, T4. And you can see that the wolf is right by this symbol of radioactivity, so I want you to also remember that this wolf and the Wolff-Chaikoff effect is going to be protecting us from our radioactive iodine, and we can use the Wolff-Chaikoff effect to protect ourselves from the effects of radioactive iodine if we administer potassium iodine to anyone who has been exposed to extreme radiation. So hopefully that silly little picture helps you remember the Wolff-Chaikoff effect. The other effect that I want to talk about is the Jod-Bastow phenomenon. And the Jod-Bastow phenomenon, or Jod-Bastow phenomenon, is the direct opposite of the Wolff-Chaikoff effect in that we are administering exogenous iodine, but this is actually going to lead to an increased production in T3 and T4. So directly the opposite effect of the Wolff-Chaikoff effect. This is going to lead to hyperthyroidism following our iodine administration, so increased T3 and T4 production. This usually occurs in patients who already have some sort of dysregulation of their thyroid hormone synthesis pathway. This could be anything like Graves' disease, toxic multinodular goiter, thyroid adenoma. So they already have some underlying pathology. Then we give them a little bit of iodine, and that is going to ramp up their T3 and T4 production drastically, leading to this uncontrolled T3 and T4 synthesis. So directly the opposite of our Wolff-Chaikoff effect, because we have increased T3 and T4 production after administration of iodine. Now, I know that was a lot of information. Let's quickly recap what we talked about in this video. The first thing I want you to be aware of is that thyroid peroxidase enzyme is going to be the most important enzyme for synthesizing our thyroid hormones attached to thyroglobulin. Our thyroid hormones are then sent out into the big brave world where they are going to bind with thyroid binding globulin so that they don't get destroyed. Then 5' deiodinase is going to convert our T4 enzyme into the more potent T3 form, and that is the form that is going to take action in most of our tissues. Perhaps the most important drugs for you guys to be aware of that act in this pathway are propylthiouracil and methimazole. These are both going to be TPO inhibitors, with the exception that propylthiouracil also acts as a 5' deiodinase inhibitor. These are both going to have an array of side effects that you should also be aware of. And then we talked about our Wolff-Chaikoff effect and our Jod-Bastow phenomenon. Wolff-Chaikoff effect, when you give iodine and the production of T3 and T4 declines. Think about our hypothermic or hypothyroid wolf over here protecting us from the effects of radiation, as well as our Jod-Bastow phenomenon, which is directly the opposite, as an increase in iodine is going to lead to an increase in T3 and T4 production. But how would they ask you about this on a board style question? Well, something they might ask you is, a patient presents to the emergency department after being accidentally exposed to radioactive waste at a job site. In the ED, the patient is administered a high dose of potassium iodide. What is the mechanism by which this medication prevents continued radiation damage? So we've just given a ton of potassium iodide. Remember back to this lecture, you'll remember that the reason that potassium iodide is effective is because we are administering a bunch of iodine and capitalizing off of the Wolff-Chaikoff effect, which means that because we've administered iodine, we are going to halt the production of T3 and T4, thus making sure that our thyroid doesn't take up any of that radioactive iodine. And since we know this is an example of the Wolff-Chaikoff effect, that would be your answer on test day, and you would get that right because you watched this video. Now I hope this video was helpful, and I'll see you next time.